Hey RMPA, we have horrible news coming out of VMC. Stay tuned to find out. A 1:5 nurse-to-patient ratio is being implemented on VMC's Respiratory Rehab Unit, or RRU. RRU has traditionally implemented a 1:2 ratio due to caring for total care paraplegic and quadriplegic patients, often requiring ventilator assistance. We interviewed several RRU nurses exploring their thoughts.
Quadriplegics that cannot move, that cannot do anything for themselves, that have respiratory complications due to their spinal cord injury. They're on ventilators, they have trachs, they need constant suctioning, they need constant oxygen boost, they desat at any given time. It would make a significant impact on the level of care that we provide, and their safety would be at risk. How can you go assist that patient if their vent pops off, or if they need suction, or if they're desatting and they need to be bagged right away? It's a huge safety risk, and they're not going to get the proper care. There's no way that they can receive the care that they need to wean off the vent, to get them better and get them stable. I would be scared every day. I wouldn't want my family member to be there at that facility.
We deal with quadriplegics, paraplegics that are injured with spinal cord injury or brain injury. At first, when we get the patients, it's hard to even communicate with them, so we're doing a lot of lip reading and finding ways to communicate with the patient effectively to be able to provide safe care. Most of the patients have high suctioning requirements, so it could be, messing with their respiratory status or delayed medications, delayed therapy times. It's definitely going to impact the patient overall. I would be pretty upset because it already sometimes feels like it's hard to be able to be providing good care when you have two patients. So to be able to be waiting for my family member to be cared for, I would definitely be pretty upset.
Impossible. I know they say we're a med-surg floor, but we're not. All our patients are on trach. Most of the time, yes, they transfer here stable, but I would say majority of the time they end up with some type of complication. Respiratory-wise, a lot of them come in with pneumonia. They have increased secretions. We've had patients that have had trouble getting weaned off the vent. So then just coming here, it's like a lot of what the doctors trial and error, trying to see what works with them, trying to get them off the vent. And like I said, most of a lot of time get pneumonia, they're on antibiotics, and it's a lot, especially with the vented patient. Oh, I'd be very upset. I would be like, well, you're not making time. You don't care for my family member because you're not in this room. I would be very upset. The unit wouldn't have the staff in case an emergency happens.
And that's really scary because, as it is sometimes when we have two vented patients, it's really hard to, be running around back and forth with the vents going off and stuff like that. Spinal cord injury patients, we have a lot of issues with their blood pressure dropping, even if they're just laying there doing, not moving. With 5 patients, I don't know how it would be possible. I can understand if they need to make changes and stuff like that, but they gotta look at the patient's safety first,
Well, they're on a ventilator, and they're vent weaning, and so they can't breathe on their own. And it's not just they're on a vent done. You're weaning them. It's a complex case. Different patients, different needs, different steps of weaning. And so how do we do that safely if we're stretched out? I don't think I'd take an assignment of 1-5 because I can't safely care for the patient. Of course I care about my license, but what tops that is I care about my patients. And if I know I can't do it safely, I won't risk it. They're counting on us. Yeah, I would escalate it to the highest. Because again, we're dealing with lives, When you see me on the floor, I'm always on the move, trying to help my staff, trying to help patients, because that's what I clocked in for. come see us on the floor. We're very open. And at the end of the day, if we're saying we just want to provide excellent, safe patient care, then we should all be on the same page. So please come see us on the floor. That would be my message.
Well, to say that to be a 1 to 5 in this unit, I think would be a big mistake because it's a big safety issue. I think the biggest thing for me is being in this unit for this long and to see the progression. I have physically seen it and worked and helped many patients get better, where they're ventilator dependent and they cannot even breathe on their own, to being off the ventilator, off a trach, going home, being in that place where they are and happy with that. I think that's just amazing to see. But that wouldn't have happened if, the ratios were higher or I wasn't able to spend that much time with them. A lot of care is going to get missed, tell you, honestly speaking. 1 to 5 for these type of patients, there's no way. In my mind, I've always, since I've worked here, the amount of care that I've provided the patients, not one day that I did go home and say, "Oof, I didn't do much today." It's always been go, go, go. And if it's not just my patient, then assisting other nurses with their patients who may be sick or having issues or having a seizure or having an RRT. It's not just, I'm going to stick to my 2 patients and that's it. We are also a big unit, a PM shift for sure, that we work together. And if somebody is struggling or if something's going on in one room, we all kind of help the best that we can. So it's not, with this 1 to 5 ratio, there's just not going to be that, right? We're just going to be so preoccupied with our own things and our tasks. It's going to become task oriented rather than what we are trying to do for them and be like, help them, be there for them, be their support system. It's just not going to be possible. I would definitely, if I was a family member, I would not want my family to be here, honestly speaking. Why should we go to this type of acuity if it's not going to benefit the patient? I think one of the messages, it's easy to look at a computer and look at a number, and a lot of times it does not reflect what we do at bedside. And I think you should come and see and work along with us to see what it feels like to be a nurse in respiratory rehab unit. It's not med-surg, it's not rehab, we're in this middle ground.
What's worrying me is that it puts our patients at risk. Honest to God, we have ventilator patients, and not all of them can use a call light to say, hey, I need suction. So then there's that. It's like, so they could be mucus plugging and we not know, or, if we go to 1 to 5, it's like, who's going to be there to catch that? If HSA sees that, what can they really do? Can they suction? No. Can they bag? Yes. But are they going to take that initiative? Or are they going to be saying, oh, I just don't know, can you just come? But I'm busy suctioning another patient that has a ventilator. So then you have like a catch-22. But our unit being 1 to 2, it allows us to treat patients more than a number. They are a person wholly. And especially after they had this incident, a life-changing accident, turning into a spinal cord, being totally independent person, to not being able to do anything. Cannot even scratch your nose. Honestly, I'd probably be looking at another rehab. I would want to see what maybe Craig would have to do. Like what's their ratio like? It would make me look elsewhere. And especially for having the county to like boast about having one of the best rehabs and yet trying to like change a very important aspect of what we do is very detrimental, because we are that stepping stone from that transition from going to ICU to acute rehab. When we get these patients, they're very new. They're on the ventilator 24/7. They don't know why they can't move their arms. They're transitioning, and they're not ready yet for the acute rehab. They have to be sitting out of the chair for 3 hours. You can't just go from ICU laying flat all day to up in the bed 3 hours, because there's a lot of things that change, like blood pressure issues, vent weaning, other things. It's such a big change for them that they need to be, basically, we have to hold their hands, our patients' hands sometimes, just to, be encouraging, being their cheerleader. But if we get more patients, we don't have the time to do all that. Support us, support the nurses, support your staff, really listen to them, listen to us. Like, we're telling you in real time what's happening and how we feel. I wish you would hear us and actually listen.
Even to think coming to work I'm going to be unsafe, and that's just not okay. Not okay at all, to have to even think about doing this, honestly. And if we're not there in the 1 to 2 minutes that are the crucial time for our interventions to happen, by the time we get there, who knows what's going to happen? And those interventions are going to not work anymore. And now we have a way, way bigger problem on our hands, Yeah, I wouldn't want to leave, honestly. I don't blame them for being like, okay, well, can we stay overnight? Like, can we have more than one person? How many visitors? I would be very nervous. That is so great. Like, there's no way. There's just no absolute. I mean, even right now, I just finished. I was in the room for an hour. I was just in the room for an hour. I put my patient to bed, gave him a bed bath, did wound care, wiped his nose, put on splints, changed the colostomy. Like, I did all these, and that was an hour. I haven't even charted yet. I say, think of the patients. Why? This is a hospital. Why are we even here? For our patients, for our nurses, for everyone that is here. We need to work together and not against each other. And just think of patient safety. I would hate for patients to stray from this hospital because we get a bad rap. They love to put us on a pedestal and say how great the rehab unit are. However, they turn around and they try and make our ratio something that is absolutely unsafe, and then they try to think we're going to be okay with that without even telling us or giving us any options. It was just like, boom, boom. It just happened.
Our typical patient is a quadriplegic, completely paralyzed on a ventilator. They require nursing to do suctioning to maintain their airway throughout the day. They cannot administer their own medications. They cannot turn themselves, so nursing turns every 2 hours to prevent skin breakdown. In order to get into the wheelchair, it's a task that typically takes 2 nurses up to an hour for patients that are on a ventilator, managing their blood pressure issues. From being in a bed for weeks on end, we typically have patients that blood pressure will fall and all the interventions that occur after that. It doesn't feel manageable. It seems very dangerous. The fact that we have respiratory issues that occur with patients every single day, you need to be available to listen and to hear their vent alarms. If you have 5 patients, your day would be spent just passing meds. Just the intervention of suctioning or cough assist wouldn't be doable. There wouldn't be staff members there to respond to people with high-risk respiratory needs. It wouldn't be safe. I wouldn't want one of my family members here. If someone's on a ventilator and they can't turn themselves, I would be very concerned that there would be a compromising event that would lead to their decline. It's not safe to not have enough hands on deck to respond to the high acuity needs that we deal with daily. I feel like management saying that we're a med-surg unit that's appropriate at a 1 to 5 staffing level needs to actually come and take a patient assignment. Every task is necessary. There's nothing we can cut out of our days. Patients need to have cough assist, they need to be suctioned, they need to be cleaned, they need to be fed, they need to get out of bed for therapy. And without having nursing staff to do those tasks, I'm just afraid for the safety of our patients.
I have another patient who's not on a ventilator, but he is trached, and he had a mucus plug. The RT had to spend a lot of time suctioning and cough assisting him. Now he needed more oxygen and humidified air throughout the day so he wouldn't create another plug. And the patient is a spinal cord patient, so his blood pressure will drop below 100, and then it will go up to the 160s, 170s, so we're constantly having to intervene to fix his blood pressure. And he's also a max assist patient. There's no way. Someone will die. That mucus plug will not be caught, and that patient will suffocate. I would be looking to transfer my family member somewhere else. The only reason why these people are able to stay on our unit is because we have the staff to respond very quickly to these types of incidents and situations.
Basically, if we go 5-1 and they give us nurse aides, you've basically signed a death sentence to these people. There's no polite way of putting this. It's not feasible. They will be dead. It takes any nurse 45 minutes to feed a patient that is got a trach or is on a vent that's eating, because they have to eat very small bites. They have to bend their head forward when they swallow. And if they aspirate, we have to immediately suction them. Nurse aides are not qualified to do that. That is out of their realm of practice. And if the patient destats, the oxygen level drops during this ordeal, the nurse aide only has the ability to call out to one of us. A lot of the administration are nurses. They just don't work at a bedside anymore. My bet is if they came on the unit in a uniform and I gave them the slowest, easiest assignment on the floor, they couldn't do it. I think it should be mandatory that all administration that hold a nursing license once a month has to take an assignment on any floor they pick in the hospital. Not sitting at the desk answering the phone. They need to be at the bedside. I think they've forgotten where they came from. On top of that, I'd like to see how they feel when their family member comes in and they have to sit at the bedside and watch what's going on and be helpless to do anything about it, all because they were too greedy and they got the pay raises.
Lastly, we interviewed a patient's wife, Bonnie Lowe.
My husband suffered West Nile virus, and one of the challenges with West Nile is that it can cause encephalitis and meningitis, which it did, and in his case has been very, very severe. So not only has he been dependent on a ventilator this entire time, which is why we're here at the respiratory rehab unit, he is also a quadriplegic because of the peripheral nerve damage. So he went from a perfectly healthy, active, robust 57-year-old man to a completely dependent quadriplegic in the blink of an eye. And we've been here since October. It's now February 17th. I think we've been here 113 days in this hospital, and we were in our local ICU for about a month and a half before that. So we've been in continuous hospitalization ever since. He needs 24/7 care. There is absolutely nothing he can do for himself. He is just now beginning to get some movement back in his fingers and hands, a little bit of trunk, upper body movement, but there is nothing that he can do for himself. Right now, the nursing situation here at Santa Clara Valley Medical Center has been pretty good. I think there's probably not a nurse or a respiratory therapist that I haven't met yet in our long stay here, and they've done a remarkable job with him. I mean, I really credit them with saving his life on multiple occasions. We've unfortunately had some setbacks where he's had to go back to the ICU, and the nurses have been there immediately to intervene, to call for rapid response without hesitation when it was needed. And so, I don't know where we would be without that level of involvement. He gets his meds probably 4 to 5 times a day. There are some that have to be given at different intervals. Some are IV, some go through his feeding tube. He has to be turned regularly when he's up in his wheelchair. It's a process. It's a multi-person process to lift him safely and get him into the chair. He has to have his position shifted like every hour so that he doesn't develop sores, either when he's in bed or in the wheelchair. He has a lot of mucus secretions that he cannot clear on his own because he has the paralysis in a lot of his, chest and diaphragm and whatnot. And so there's a machine called a coffilator that we use regularly throughout the day to clear those secretions. Without it, he would suffocate. So it's just it's constant ongoing care. He needs bowel support. He needs feeding through his stomach tube, cleaning of all of those entry points. personal care, hygiene, oral care, and then just, the little things like making sure that he's comfortable and asking him if there's anything he needs, occasionally giving him ice chips. Those are things that the nursing staff does, whether I'm here or not. I've been really fortunate that I've been able to be by his side this entire time. But, most people can't do that. And I know I'm very grateful that we've been in a position that we've been able to do this. But even with that, it's overwhelming. And I see the overwhelm for our nurses too. They want to do more. They want to do better. They want to support him. They want to support me. The thought that his care could be reduced scares the hell out of me for anybody. It's not right for the patients. It's not right for the families. And it's not right for the nursing staff either. I mean, I get it. I was in local government for almost 20 years. I understand how budgets work. I understand how difficult it is. But these are people's lives. And there is no justification. It doesn't matter what the budget is. We are in the wealthiest state in the nation. We have the resources. We need to allocate them appropriately. We have to put patients' lives first and patient outcomes first. It can't be about census. It can't be about numbers. People won't survive. They won't thrive if we don't put them first. So there's no two ways about it. Thank you. And we're supposed to go home on the 27th. Crossing my fingers. I'm going through a lot of training right now with the nurses. I mean, I'm doing their job right now because I have to learn it because it's on me when we go home. And so it gives me a unique perspective just how hard it is and how constant it is and how vigilant and how much you have to pay attention to detail. It's such a critical role.
The recent staffing changes at VMC highlight a broader issue in our healthcare system that compromises patient safety. We cannot stand idly by. A press release event is in the works aimed at spotlighting these critical staffing issues and reinforcing our commitment to patient safety above all. We call upon every RNPA nurse to stand with us. Details of the press release event happening next week will follow via email. This is our chance to unite for the safety of our patients and to advocate for the necessary staffing standards our healthcare system desperately needs. Stay tuned for updates, and remember, our strength lies in our unity and our unwavering dedication to patient care. Thank you for your continued support, and stay RNPA strong. If you enjoyed this video, please like, subscribe, follow, double tap, and comment below to let us know how we're doing. All of it really helps to get the video out there. Thanks again for watching, and we'll see you in the next one.